right. Good afternoon, everyone. Hope that you can hear me and see my screen. My name is Elizabeth Coe. I'm an internist, primary care physician, and the medical director of the Integrative Medicine Collaborative. So thank you for sharing your lunch with me. And on the topic of lunch, I am taking bites of my own lunch, and we're going to be talking about nutrition as well. So I have a presentation that's about 30 minutes, and then I'm going to open it up for conversation, for dialogue, for questions. This topic always generates a lot of rich discussion. So just to amuse me, if any of you would mind participating either by chat feature or if you want to show your video, how many of you have ever been told you have a cholesterol problem? Okay. How many of you have perfect cholesterol? All right, and I'm just anticipating and seeing what your answers are. Thank you for Sandy Cohen. Yep, not perfect. Me. Okay, great. So one of the principles of integrative medicine, which is what I practice and I subscribe to, is the integration of bringing in lifestyle interventions, which is nutrition, exercise, stress management techniques, it's supplements to complement Western medicine. So we believe very much in the power of Western medicine. I think for acute emergencies, for acute infections, Western medicine is very good. But when I see patients and diagnose them with a problem, whether it's type 2 diabetes or obesity or cholesterol, the first thing I say to them is this. I say, I can give you a prescription, or I can coach you how to heal yourself. And that's a really powerful statement. And I'll tell you, most patients opt for the latter. More and more patients want to be active participants in their health, not just taking prescriptions or being the recipient of an intervention, but patients want to be proactive in their care, right? With both managing disease and also with a health promotion as well. So let's talk through statins, and let's see how we can optimize our cholesterol through nutrition. Okay. So this is my outline. I'm going to talk to you about different cholesterols. There's not all cholesterol is bad. There's good cholesterol and there's bad cholesterol. We're going to talk about this idea of dyslipidemia, who to treat. We're going to talk about statins, why statins, and then I'm going to walk through these food categories, right, which is fat, fiber, phytosterols, supplements, and exercise. And I will say, as I progress through this presentation, if you have any questions in the chat, please put them in. I'll get to them once I'm done, and then we'll have a discussion. Well, I already see one as well. Great. Okay. So first things first, understanding cholesterol. Okay, so what is cholesterol? Cholesterol is essential. We need cholesterol for every membrane in our cell, and we also need it for hormone production. So the building blocks of hormones is cholesterol. How do we get cholesterol? We can either get cholesterol through our liver. Our liver makes cholesterol, and it's also ingested through food. The primary sources of cholesterol are animal sources. So it's meat, poultry, full-fat dairy, and eggs. Okay. Also, the liver produces more cholesterol when there's a diet that's high in these bad fats that we're going to review. All right. And then also the cholesterol is carried through the bloodstream by these lipoproteins. This is an important point that we need to emphasize, is that there is good cholesterol and there's bad cholesterol. So LDL is bad cholesterol. We want it to be low. I remember that by L. L is low. So LDL is low is the goal. Okay. HDL, which is good cholesterol, should be high. And we made it very easy for you to remember because LDL, low, HDL, high. That's how you remember, okay? So for all of you who have had your annual physical, almost always a lipid panel, I also call it a cholesterol panel, is included. And this is what it looks like. If you have My UCLA Health, this is what the results look like when you see your results in the portal. So there are 4 parts of a cholesterol panel that I want to highlight. So the first is the total cholesterol, which is this first point here. I don't put too much stock into this. This is not a very important value because it doesn't differentiate between the good and the bad. So I see it, I recognize it, but more important are these 3 parameters that I'm going to mention. So the LDL cholesterol, we mentioned L should be low. So LDL is bad cholesterol. We want it to be as low as possible. The reference range for the UCLA lab is less than 100. So this patient's cholesterol is 82, pretty good. HDL should be high. H is high, so HDL is the good cholesterol, so we want HDL good cholesterol to be as high as possible, so the UCLA reference is greater than 50. So this patient's cholesterol is 76, pretty good. Triglycerides are the free-floating fat in your bloodstream. We want it to be as low as possible. So this patient's cholesterol, triglycerides is less than 150 of the goal, which is 71, which is great. Okay, so LDL should be low, HDL should be high, triglycerides should be low. I review hundreds, if not thousands, of cholesterol panels every year, and I would say this is a good cholesterol panel. So cholesterol panel, lipid panel, I use them interchangeably, but lipid is kind of the medical term, so the way you'll see it on your results is lipid panel or lipid profile, but we can also say the word cholesterol panel as well. So I would say A+ results for this patient. Okay, so this is an example of a patient who may need a little bit of help, who may need to attend this webinar and learn a little bit about how to optimize cholesterol. So LDL bad cholesterol is 140, it's a little bit too high, we want it to be 100 or less. HDL, good cholesterol, is a little bit low. We want it to be as high as possible. So 42 is a little bit low. And triglycerides, which are the free-floating fat, is also a little bit high at 230 as well. So, you know, it's flagged yellow. Now it's actually red, sign of danger. So this is a sign of what I call dyslipidemia. Okay, so dyslipidemia means cholesterol that isn't ideal. It's LDL high cholesterol, HDL low cholesterol, and triglycerides that are too high. All right, so let's talk about LDL. So LDL is the bad cholesterol. I've said it 18 times already. We want the levels to be low. Why? Because elevated LDL is a risk factor for atherosclerosis. That's a big word. That means plaque formation leading to a clot. So atherosclerosis happens in our arteries. Plaque develops just the way plaque develops in our teeth. You know, it's kind of this buildup, right, of gunk that eventually can lead to a clot. And that's what we call a heart attack. So we don't want plaque because plaque is debris and that can lead to a clot, which can eventually cause a heart attack, which no one wants. Okay? And LDL is the primary target for cholesterol lowering treatments, which are medications. Okay, so this is a picture of a coronary artery. It's an artery in the heart. And then what happens is the LDL that you ingest through food can get deposited into the vessels. It gets activated by these macrophages, and then it activates the lining of this endothelium, which increases the risk of plaque formation and eventually clot. So this is a process we don't want. HDL is high density lipoprotein, and this is the good cholesterol. So we want this to be as high as possible. The beautiful thing about HDL is that it actually lowers LDL. So it has this dynamic effect of, you know, of bringing the LDL from the tissues to the liver to excretion. So it negates the effect of LDL. We know that an increase in HDL of 1 decreases the risk of heart attack and cardiovascular death by 6%. So an HDL of greater than 60 is cardioprotective, so we want this to be as high as possible. What are some reasons of low HDL, which is what we don't want? We want high HDL, but patients who are overweight, obese, who are physically inactive, or who smoke cigarettes can have low HDL. These are reversible causes, right? So if we can really work on maintaining a healthy weight, exercising, and not having toxic exposures, that will help improve and elevate our HDL. Triglycerides. So triglycerides are the free-floating fat in our bloodstream, and they store the excess energy from diet, and we want low levels. So triglycerides should be low. We don't know whether high triglyceride levels causes atherosclerosis. This is controversial and being under investigation. So what are some reasons for high triglycerides? I list them here. Overweight, obesity, physical inactivity, cigarette smoking. That's the exact same as the prior slide of reasons for low HDL. Also too much alcohol and too many carbs, with things like rice, bread, pasta, sugar, starchy foods that can cause high triglycerides as well. Another observation is all 5 of these items are also focused items that we can work on and potentially reverse to help improve our triglyceride levels. So when I see a panel like this with high LDL, low HDL, and high triglycerides, this is what we call dyslipidemia. And I like to use the word dys because dys means faulty. So this is a faulty cholesterol. Sometimes you'll see the word hyperlipidemia, but hyper means high. And you know, that would mean that the LDL is high, the triglycerides are high, but we know that the HDL should be high. So rather than use the word hyperlipidemia, I think that the word dyslipidemia is a little bit more accurate, reflecting this probably C- cholesterol panel. So what are some causes of patients who would have a panel like this? So sedentary lifestyle, poor diet, which we'll focus on, overweight and obesity, cigarette smoking. You've seen this 3 times already. We know that making positive changes to our lifestyle, engaging in more self-care strategies can really help improve our cholesterol along with other metrics of health. Also, there are some medications that can negatively influence our cholesterol. So steroids, hopefully none of you are on long-term steroids, but steroids do negatively impact cholesterol. Hormones can, so women on birth control pills or postmenopausal women on hormone replacement. Thiazide diuretics, examples are hydrochlorothiazide, can negatively impact cholesterol. Also some antipsychotic medicines, so medicines like Seroquel or Abilify, which sometimes are used to augment depression management, can also negatively impact cholesterol. Finally, if you're doing everything right, and if you're exercising, eating well, you're at a healthy weight, no bad habits, not on any meds, and your cholesterol still looks miserable, then it's genetic and you blame it on mom and dad. Okay, so let's go to dyslipidemia, who to treat. Okay, so who do we treat? So you have this cholesterol panel now, maybe it doesn't look so good, but which patients should be on medication? This is an important topic that is always evolving and we can't really agree on consensus. So there were guidelines from 2002, they were called the ATP3, and the focus was on a target LDL. So this was a commonly accepted guideline was, for low risk individuals, healthy young people, we want the LDL to be less than 160. For moderate risk, high risk, the goals were 130 and 100 respectively. And if you had cardiovascular disease, if you've had a heart attack or a stroke, then the guidelines did recommend an LDL of less than 70. However, the guidelines were recently updated in 2013, so a couple of years ago, and now the focus is on the overall risk of a patient and not just one number and one goal. Okay, so these are the groups who benefit from statins. So if you meet any of these criteria, the guidelines, the American Cardiology Association, American Heart Association guidelines do say that yes, you should be on a statin. So if you have had clinical ASCVD, ASCVD stands for atherosclerotic cardiovascular disease, meaning if you have known heart disease, if you've had a stent, if you've had a heart attack, if you've had a stroke, if you've had peripheral vascular disease, if you have known heart disease, atherosclerotic disease, you should be on a statin. The guidelines are very clear. If you have an LDL greater than 190, I'm sorry, you should be on a statin. Also, if you are diabetic in that age group with an LDL between 70 and 189, you should be on a statin. So these were what the guidelines agreed upon is if you meet any of these 3 criteria, you should be on a statin. The interest is of this number 4 group, which is individuals without having a heart attack or stroke or diabetes who are within this age who have this 10-year risk of greater than 7.5%. So many internists, primary care physicians, cardiologists will use this calculator. It's called the ASCVD risk calculator. It's available as a calculator online. We have an app as well that we use, but it takes these variables, your age, gender, race, total cholesterol, HDL, blood pressure, if you're on medicine for blood pressure, diabetes, and smoker, and you fill this in. So you go onto the website, you put in your numbers. This is a 65-year-old man, African-American. This is his cholesterol panel. Blood pressure is 130/70. He smokes cigarettes. So you put in all these numbers and you press calculate, and the calculator will give you this number, okay? So this is a risk of 17% of heart attack or stroke over the next 10 years. So the guidelines do say if your risk is greater than 7.5%, then the recommendation is to be on cholesterol medicine, okay? I want to emphasize that this is simply a tool. This is a tool that helps guide clinical decision-making. A tool is simply a tool, and it's not a hard and fast yes or no. So some patients have a risk of 20% and choose not to be on cholesterol medicine. Some patients have a risk of 5% and opt to be on cholesterol medicine. So 7.5 is the golden number, but we have to recognize that it comes to a shared decision-making process between the physician and the provider, okay? So again, this is called the ASCVD calculator, and a search on Google will bring you right to this calculator. There's also an app as well that I use all the time in my day-to-day practice, okay? So the summary of cholesterol medicine, we're moving away from treating a lab value, recommending the use of proven medicines called statins, and treating patients who have the most to gain, involve the patient in the decision-making process. Okay, so now we have to talk about why statins, why these medicines, okay? So You have seen these medicines before. They consistently are in the top 10 most commonly prescribed and the highest generating revenue of all prescription medicines, along with other common medicines that we use. So the generic name is listed here, and the brand name is in parentheses. So Crestor, Lipitor, Zocor, Pravachol, Mevacor, these are commonly prescribed ones. I would say the more common ones are the top 3. Okay. How do they work? So they block this enzyme called the HMG-CoA reductase. So if you see on the diagram on the right side, this is how the liver makes cholesterol. So there's this process, but if we block this enzyme, then the liver can't make cholesterol. So that endpoint of cholesterol is not there. So that's blocked. So as a result, the liver can't make cholesterol and can't make LDL specifically. So also too, they increase the number of LDL receptors. So there's more cholesterol removed from the bloodstream as well. So it's a dual dynamic effect. And I'm just sharing you data to show that statins do work. There is a rich amount of research showing that statins do work. They reduce LDL. This is a trial of 90,000 patients, and we know that LDL decrease corresponds to reduction in a myocardial infarction. An LDL reduction of 38 points reduces a 22% reduction in cardiovascular events. And the literature across the board does show that statins do reduce all-cause mortality, death, non-fatal heart attack, coronary revascularization, stroke, peripheral artery disease, and heart failure. So this data is really rich. No one will argue with this. You know, most cardiologists will, there's jokes that statins should be in our water supply, right? Because of the benefits that are there. And the literature, again, is very strong. Okay. What are the side effects? So the most common side effect that everyone knows about is myalgias, which is a fancy word for muscle aches. And it's not just a little muscle ache in a little part of the body, it's head to toe muscle aches. It's 3 to 15% of patients. If you do experience muscle aches with statins, here are some suggestions. One is you can change to a different statin, okay? There are some that are more myalgia prone. There are some that are less myalgia prone. Another option is you can add coenzyme Q10. Coenzyme Q10 is depleted in the pathway that we saw. So in addition to decreasing cholesterol, it decreases coenzyme Q10. So adding coenzyme Q10 can help offset some of the statin-induced myalgias. Typically the dose is about 100 to 200 a day. We can also reduce the dose as well too. So these are 3 suggestions if you do experience the myalgias of statins. Liver toxicity is very rare, and I will just mention cognition and diabetes as controversial side effects. Okay, so I am showing you this chart to see and to demonstrate how the various cholesterol lowering agents affect LDL, HDL, and triglycerides. Okay, so the statins again are the best studied. They do lower LDL a lot depending on the dose and the formulary, but up to 50%. It does also raise HDL and lower triglycerides. So it has the triple effect of great news for all 3 of the parameters. There are also bile acid sequestrants. An example is cholecystiramine. That does lower LDL. Zetia is also called ezetimibe. You can see the effects there. And then other medicines like fibrates, like fenofibrate, do have more of a powerful triglyceride lowering effect, as does niacin and fish oil, which is omega-3 fatty acids. All right, so now that I've convinced you of the beauty of statins, now how can we avoid them is the question, right? So let's talk through fat, okay? So dietary fat, there are 3 types of fat. There is saturated fat, trans fat, so actually 4 types of fat. Saturated fat, trans fat, polyunsaturated, and monounsaturated, okay? So let's look at some examples. Monounsaturated fat are plant-based sources. These are the good fats that we hear about all in the news. So we want olive oil, canola oil, olives, nuts, avocado. These are plant-based fats. They are generally liquid at room temperature, and they are heart healthy. Polyunsaturated fats, examples are fatty fish, some other plant-based oils like soybean oil and corn oil, and flaxseed oil, okay? Saturated fat is anything that's solid at room temperature. So it's mainly animal-derived fat. So red meat has the fat that you see in burgers and steak. That is saturated fat. Dairy, so anything from cow's milk, whether it's butter or ice cream, and coconut milk, which I know is very controversial, but tends to have more saturated fat, even though it's a plant-based source. Trans fats are really an absolute no. And I don't say a lot of absolutes in my practice, but trans fats are an absolute no. They are man-made. Things like margarine, shortening, and partially hydrogenated oil should really be eliminated from your diet. And I don't use the word eliminated very loosely, but eliminated is the case for trans fats, okay? So here is a summary of goodness versus badness. So we want monounsaturated and polyunsaturated fats. And then saturated fats, I'll tell you, are a little bit controversial. Trans fats are an absolute no. Okay. Here's a chart that shows the various fats and their breakdown of saturated in blue, monounsaturated in teal, and polyunsaturated in yellow. So the top of the list has more of the mono and polyunsaturated predominance, whereas the bottom of the list has more of the saturated. So like I mentioned, coconut oil tends to be controversial. It is mainly 90% saturated fat, even though it's plant-based. You can see on the bottom, butter, beef tallow, lard, those are all saturated forms of fat. So we really want to try to preference the fats on the top of the list. And I would say olive oil, even though it has a little bit more saturated fat, I think is my preferred method of, or my preferred form of oil. Okay. So let's see how now monounsaturated fat, polyunsaturated fat, saturated fat, and trans fat affect LDL, HDL, and triglycerides, okay? So monounsaturated fat, like I said, plant-based fats are all great forms of dietary fat. You know, we have to understand that not all fats are bad, right? It's the type of fat. So I don't want you to be afraid of these plant-based fats. So olive oil, olives, nuts, avocado can actually lower LDL and raise HDL. That's a great effect. We want that. Polyunsaturated fats, same effect. So fish, flax oil can lower LDL and raise HDL. So these are fats that we want to focus on. This can have a positive impact on our cholesterol. Saturated fats are really to be studied. You know, there's some, you know, you would think that too much red meat, too much dairy would negatively influence cholesterol. It can raise LDL, but it can also raise HDL as well too. So there's more and more studies showing that there isn't as strong of a correlation between saturated fat and heart disease. So the jury is still out. Trans fats, again, should be absolutely banned. So they have a negative impact on all three parameters of cholesterol. It raises LDL, lowers HDL, and raises triglycerides. So you see in the blue, main message here, let's focus on the plant-based fats. Saturated fat, I would say enjoy in moderation if you really find joy to these foods. And then trans fats, absolutely no. Okay, so here's our quiz. Walnuts, monounsaturated fats. They raise HDL and they lower LDL, a great choice. This is a filet mignon. Okay, so does it raise LDL and HDL? Yes. Okay. Crisco, which is, I know, a major presence on many of our grandmothers' kitchens, you know, blue bottle. Yeah, so what do we say about Crisco? Absolutely no. Okay, so it raises LDL, lowers HDL, and raises triglycerides. Butter, okay, so it's a saturated fat, right? It's solid at room temperature, it's animal-based, so it does raise LDL, but it also raises HDL. So I tell my patients, if you really enjoy butter, enjoy it in moderation. I think that olive oil is a better choice. Olive oil lowers LDL, raises HDL, a great choice for plant-based fat. Avocado, same thing, monounsaturated fat, lowers LDL, raises HDL. Fatty fish like salmon carry great omega-3s, polyunsaturated fats, lowers LDL, raises HDL. All right, okay, so let's talk about fiber. There are two types of fiber. Fiber comes in insoluble form and soluble form. So insoluble, think of it as the parts that don't get digested through your tracts. So things like, you know, like apple skins or kale or any of the, it doesn't dissolve in water, so it's insoluble. This is really great for constipation or for digestive health, insoluble fiber. What I care about more and what more positively impacts your cholesterol is the soluble fiber. So soluble fiber, I think of the word S as sponge. Think of the foods that make kind of a gelatinousy material. Okay, and I'll show some examples later on, but think of foods like chia seed or okra. They contain a lot of soluble fiber, and that's what makes that gelatinousy material. S for sponge, it carries a lot of water. It also does have improvement with lowering blood pressure and insulin resistance as well. So soluble fiber is a great cure-all for blood pressure, cholesterol, constipation, and sugar. Okay. So here are some examples of soluble fiber. Again, it's that gelatinous-y material, that gelatinous quality that you get when you mix it with water. So, you know, you mix your oatmeal with water, it's that kind of gelatinous-y material. Beans as well have a great source of soluble fiber. Dried figs, dried prunes, sweet potatoes, not pictured here also with great sources of soluble fiber are chia seed. You've all taken chia seed and added it to water, and you see that how much water does it absorb? It's such a sponge. And also kiwi. Kiwi is a great source of soluble fiber as well. Okay. This is data showing you from 67 trials that soluble fiber of 2 to 10 grams a day reduces LDL by 22 points and total cholesterol as well too. Okay. And if you, I always prefer food-based sources of soluble fiber. If you prefer a supplement, or if you can't consistently incorporate soluble fiber in dietary sources, Metamucil is a good option. The active ingredient is psyllium seed husks, and it contains 70% soluble fiber, and you can generally get in more of this than you could through food, okay? Some people take Metamucil as a bulk-producing laxative, again, supporting the idea that soluble fiber not only improves cholesterol, but also good digestive health as well. Okay, so now let's turn to phytosterols. So phytosterols are cholesterol-like compounds found in plants and vegetable oils. So they are food-based, plant-based sources, and they can be found naturally in food. I'm going to show you a list in a minute, or they can be bought as a supplement as well. So phytosterols do lower LDL by 9 to 20% without an effect on the HDL or the triglycerides. They do inhibit cholesterol absorption from the GI tract. There are some purified plant sterols and stanols that can be added to foods as well. Okay, so this is a chart that I'm sharing with you. Wheat germ has a lot of phytosterols. Not many of us can eat half a cup of wheat germ a day, but there are some other sources of oils and nuts and other food sources that do have some phytosterols. I will highlight the two items at the bottom, which are take control spread and Benecol spread. These are plant-based sources of margarine, so they're not trans fats, but they are plant-based sources, and they do have added plant sterols and stanols in pretty high amounts. You can see here per serving. Supplements. All right, so these are the 5 supplements that are commonly used to treat cholesterol, and I'll go through them one by one. Okay, so red yeast rice is a very common supplement. Okay, it is a fermentation of a rice with this yeast, Monascus purpuris, and it contains this ingredient called monocolin. Okay, and it is essential. So the statins that are prescription strength were actually derived from red yeast rice. So red yeast rice has this ingredient, monocolin K, that very similarly mimics the prescription commercially made statins. Okay, so patients find that if you can't tolerate a prescription statin, this is something to try. The recommended dose is 600 twice a day or 1200 twice a day. The main side effects are headache and some GI discomfort. This is data showing you from a small trial that patients who had dyslipidemia and statin-induced myalgias were randomized to either red yeast rice or pravastatin, which is a conventional statin medicine, and there were less myalgias seen in the red yeast rice group compared to the pravastatin group, and the LDL reduction was about the same. Niacin is also known as B3. It works by decreasing LDL and triglycerides, and it does increase the HDL. There is a small side effect of flushing, and some people will take aspirin an hour before. Don't purchase the over-the-counter no-flush preparations because it doesn't contain the free nicotinic acid, which is the active ingredient in niacin. Artichoke leaf extract. There was a Cochrane review, which is a robust review looking at 3 randomized controlled trials of 262 patients. And the conclusion is that there is an indication that artichoke leaf extract has a potential to lower cholesterol, but the evidence is not convincing. So what I say, probably wouldn't buy a artichoke leaf extract, but maybe just try to incorporate more artichokes into your diet, whether it's the canned artichoke hearts or just artichoke leaves that you eat and steam. Green tea. The active ingredient is called catechin, and we know that green tea can lower LDL. The studies do show a high amount of tea, so it really is 6 to 7 cups of tea a day, which not many people can tolerate. But if you enjoy tea and enjoy the calming effects, the taste, just know that this can also help lower LDL as well. Okay, garlic. So a lot of interest in garlic. A meta-analysis of over 13 trials does show that garlic was better than placebo at reducing cholesterol, but the benefit was small. The German Commission E, which is kind of equivalent to the FDA, has approved garlic for hyperlipidemia. Okay. What I say is maybe not worthwhile to take garlic supplements, but just incorporate more garlic in your diet. Okay, cook with it, eat it, and it's delicious. It's low calorie, and it can also help improve cholesterol. Okay, and then finally, exercise. So exercise has an impact mainly on the triglycerides. So exercise can lower triglyceride levels. It can also increase HDL by a little bit, but it's mainly pronounced in those who have high triglyceride levels. There isn't too much of an LDL effect unless there's exercise-induced weight loss that comes with it. So mainly by reducing triglycerides and increasing HDL. Okay. So this is my last slide and the summary. We need to know that there are bad cholesterol and good cholesterol. So the good cholesterol is the HDL, the bad cholesterol is the LDL. We want the LDL to be as low as possible. We want the HDL to be as good as possible. Statins can be for the right population. If you've had a stroke or a heart attack or a stent, I would encourage you, even as an integrative medicine provider, take your statin, okay? The focus is really on the plant-based fats, polyunsaturated, monounsaturated, saturated fat, I would say in moderation if it's a part of your preference, if you enjoy the taste, knowing that the impact on cholesterol is of lowering not just the, raising not just the LDL, but also the HDL as well. Trans fats to be eliminated. As I said, hard and fast rule, really should be removing those from our diet. And then incorporating more whole foods, right, into a plant-based diet. In general, if you eat real food, not too much, mainly plants, that's the foundation for a healthy diet. Maintain a healthy weight. We know that patients who are overweight and obese tend to have higher, more dyslipidemia. And also minimizing toxic habits. Both alcohol and smoking can raise triglycerides and lower HDL. This is being recorded, so I know I went through pretty quickly. So this will be available to you on the Integrative Medicine Collaborative website. All right, I'm going to stop sharing my screen now, and then I'm going to take a look at the chat questions. Also, if you want to turn on your video and ask a question in real life, I definitely encourage that as well. And I think there's always great